Welcome, friends, to Faith in Healthcare. I'm thrilled to share that just a few weeks ago, we had an incredible national convention in beautiful Loveland, Colorado, bringing together over 1,150 of our CMDA community from across the USA for an incredible, unforgettable experience. We gathered to be equipped, encouraged, and reminded of the unique opportunities that we have as Christian healthcare professionals to share the hope and healing of Christ, not only in our local communities, but also as part of regional, national, and global communities. The energy was so incredible, especially with more than 225 students and residents joining us. It was a tremendous blessing for everyone. During the convention, I had the joy of sharing my own personal CEO challenge to the Assembly, the unveiling of our new CMDA brand promise, which is Your Faith and Healthcare Connected. 5 simple words, but so powerful. Those faith and healthcare connections include engaging in biblically informed bioethical debates on the critical issues of our day, transforming lives through 5 CMDA ministries, which focus on proclaiming the gospel on a daily basis through healthcare missions efforts in the States and around the world, through reaching the next generation of healthcare professionals with significant growth in undergraduate and graduate campus ministries. You know, we're approaching 400 campus groups across the U.S. Well, on Saturday, I also had the privilege of announcing our fiscal year-end giving campaign. Our goal this year, friends, is $1.1 million by June 30th. It's definitely a stretch goal, I'm sure you'll agree, but no surprise, the Lord has already been working to help us meet this goal. A group of CMDA donors have stepped up to inspire all of us to consider our support by offering to match the first $245,000 that's given. So I want to thank you for prayerfully considering your best gift of the year to help meet this goal by June 30th. It will keep your CMDA strong and ready to serve locally, nationally, and globally through these many ministries to and through healthcare professionals. If you want to give your gift today, just visit cmda.org/give or just call our stewardship team at 888-230-2637. Many thanks for prayerfully considering your gift today. You know, that commitment to engaging the critical bioethical issues of our day is exactly what today's episode is all about. The conversation around hormones and surgery for children and adolescents who are struggling with gender confusion has been one of the most controversial and ideologically driven in modern medicine. In this episode, Dr. Brick Lance and I are joined by Dr. Scot Glasberg, who's a world-renowned plastic surgeon and past president of the American Society of Plastic Surgeons, known as ASPS. In February of this year, Dr. Glasberg led the ASPS to issue a landmark position statement urging our medical community to stop performing gender-affirming surgery on children and adolescents, those who are under the age of 19. This was a courageous, evidence-based stand that sent ripples all across American healthcare. Well, join us right now as we explore what it means to follow the evidence when the culture is pressuring us not to, in order to protect vulnerable patients and to do no harm above all else. Well, today on Faith in Healthcare, we've got Dr. Scot Bradley Glasberg. He's a world-renowned plastic surgeon with a private practice in New York City, a long history of consulting in the biotech industry, and has a special interest in regenerative medicine and evidence-based surgery. And that's going to play a big role in our conversation today, is Scot Glasberg's attentiveness to evidence. He has served as president of the American Society of Plastic Surgeons, the Plastic Surgery Foundation, the New York Regional Society of Plastic Surgeons, the New York State Society. I could go on and on, Dr. Glasberg. You've got more leadership positions than I have fingers and toes. So, welcome to Faith in Healthcare, and our listeners will be able to get all of your CV on our show notes today.
Thank you for having me.
And today with us, listeners, you're accustomed to hearing his voice, Dr. Brick Lance, our Vice President of Advocacy and Bioethics, fresh off the boat from or the plane from Oregon.
Yeah, well, thank you, Mike. It's a pleasure to be here with both you and Dr. Glasberg.
Yeah. Well, Dr. Glasberg, I was made aware of your position and past statements from the American Society of Plastic Surgeons by a mutual friend, Dr. David Larson out of Milwaukee, who's emeritus professor there from Medical College of Wisconsin. And thank you for accepting our invitation, coming at such a critical time as this, when we have this discussion about what has been historically in the last decade called gender affirmation surgery. So thank you again.
No, thank you for having me. And yes, Dave Larson is a close friend and longtime mentor. Interestingly enough, I met Dave as a resident when I was training in plastic surgery, and he was in a prominent position with the American Board of Plastic Surgery, and just from there on took off, and he was a longtime mentor and friend.
Dr. Glasberg, would you tell us when exactly what period of time the president of the American Society of Plastic Surgeons?
Sure. I was president of the American Society of Plastic Surgeons from 2014 to 2015, and then subsequently made my way up the other side, the Plastic Surgery Foundation side, and was president there from 2023 to 2024. And I was fortunate, I say, and honored, because only a few people have ascended both the realm of both societies. And in addition, as it'll play out in our conversation here, I'm one of the few, if not only two, private practice plastic surgeons who have served as the president of the Plastic Surgery Foundation. And I mention that because I realized that when I started to ascend that side of the society, that being the research and charitable arm of our society, I took it upon myself. Patient safety has always been in my realm and something I've lectured on, but evidence, while it was important to me, I really wanted to become an expert in evidence review and science and data from that standpoint. So I took it upon myself during that ascension to really study and become intimately involved with the evidence surrounding many of the procedures that we do in plastic surgery, and I'm sure in our conversation now that will come up as a key part of what we're going to talk about.
So, Dr. Glasberg, for our listeners' benefit who may not be aware of the guidelines, both from 2024 as well as just in the last couple of months that have come out of the ASPS, just tell our listeners what the guidelines were like in 2024 and then what your recent update was.
Sure. So we began an iterative process at ASPS of reviewing the data, science, and evidence in the realm of gender-affirming surgery. We were looking at the whole thing, gender-affirming care as well, which includes endocrine and hormonal therapies, probably over the last 3 to 5 years. But there was a transition point in about end of 2022, early 2023, when we started to look at the data and realize that it seemed to be of low evidence and low certainty. And I'll explain a bit what that means in a minute. But with that path, in 2024, right after about the CAS report came out, that was the large government-funded study out of England looking at gender-affirming care, and where Hilary Cass, who I've spoken to, realized that the evidence in the entire field in this realm was of low certainty, low quality. We then realized that we needed to come out with a statement as well, since it was just confirming what we already saw. And so in August of 2024, we released a statement. I did many interviews with the media, basically telling our members that the evidence in this realm, gender-affirming surgery for adolescents and children, is of low quality and low certainty. And for that reason, they should take caution. Well, over the ensuing about year and a half till February 3rd of 2026, to which you're referring, that review of the evidence continued on. And finally, ASPS took the position on February 3rd of this year to state that it felt that gender-affirming surgery for children and adolescents should be postponed until the age of 19. And we took that position on surgery because that's our expertise.
Right.
The rest, while it also showed low certainty, low quality evidence, it's just not the realm that which we work in. And what that meant is a position change for the society, a bit, or I would say an evolution of the statement and the policy. And now, the way it's been viewed by others, and again, I don't mean to speak for other societies, but it is a change in the realm of the medical field as to a position which is different than other societies have taken. That's probably why, and we were the first, probably why we got so much attention in the media and from a variety of sources.
Yeah, Dr. Glasberg, and I appreciate that. And I would even state back in August of 2024, when you had what most people would call a neutral statement, that was also unusual for a medical society to do that. So you were even off the scale then, and then now evoluting to this time of February of this year with your statement essentially against gender surgery for children and adolescents. So here's my question of the pressures within your society. If you can take us through the internal workings of your society and the discussions. There is the scientific evidence which you have followed, but this is a divisive issue within our culture. So were there other pressures? Medical, legal would be one, public opinion, policymakers, ethical considerations, because there's an ethical concern as well. What were the other pressures in formulating your new statement of February this year?
Loaded question. We need 2 hours here. So let me start with a general statement about our society. And what I mentioned earlier, I really believe that patient safety and evidence review is a core basis of what we do at ASPS. And so let's say politics never plays into that decision.
Okay.
We really want to do what's in the interest and well-being of our patients.
Okay.
So with that as the background, I think you're correct. 2024, we were called out as well for being the first one to take even that position. You said it as neutral. It was probably a little bit over neutral. And then, we've sort of evolved now to where we are. I think all of those things are considered. You're absolutely right. This is a very controversial issue. And I think it was Ronald Reagan who probably said that if I'm making everyone happy, I'm probably not doing a good job. And so we realize that, and we've interacted with those who disagree with the position statement. You've probably heard there's been a petition that was signed by about 300 plus surgeons. But the vast majority of the responses that we got to the statement have been incredibly positive. We have 9,000 members in the United States, 11,000 plus worldwide. And it's been, pretty consensus-based, positive for what we've done. In terms of ethical considerations, which I know is your expertise, that's a huge part of what we're doing here. Adolescents and children are, as you know, a vulnerable population, cannot generally consent to procedures on their own. And so we have to take all of that into account. What most compelling, I think, is the fact that from a clinical standpoint, from a standpoint of doing what's best for our patients, it is impossible, based on the current data, to make a positive risk-benefit ratio for these procedures for patients. And that's the essence of what we do as physicians, surgeons, plastic surgeons, every single day. I assess for a patient, what is the risk? Does the benefit outweigh the risks? And here we couldn't come up with a positive equation for that. And given the fact that that's simply the basis of everything we do, that's an important consideration, to say the least. The one last thing I will note is, and we'll probably talk more about this as the conversation goes on, is these surgeries are irreversible, just basically irreversible.
Right.
And that has to be a huge ethical and clinical consideration when considering doing these surgeries on patients.
Of course, Dr. Glasberg, we are part of a team. You point that on the position statement. We are part of a multi-specialty team with these children and adolescents who are suffering with gender dysphoria or incongruence. And outcomes are mental health outcomes. So clearly our mental health specialties, professionals who are working in our teams are so vital in this process, before, during, and after. And there have been a lot of studies that have come out over the last decade in terms of these mental health outcomes and whether it's hormonal or surgery interventions for those suffering with gender dysphoria. What do you think about the recent study that just came out from Finland? 23 years, because you're watching and it's just, if I can just briefly read their conclusion, regardless of gender, adolescents suffering from gender dysphoria present with excessive psychiatric morbidity. Subsequent to medical gender reassignment, psychiatric treatment needs appear to increase. It should be noted that in some individuals, medical gender reassignment appears to be linked to deterioration in mental health. So there's a massive study, 2,000 patients compared to 16,000 matched age controls. So I assume that supports your cause a little bit.
Absolutely. I saw that paper the day it came out, and of course, leave it to the Finnish to be ahead of us because, that whole block of Europe is clearly ahead of us. They were 10 years ahead of us in terms of treating these patients. I think they learned from their ways. I believe we should learn from their ways, to your point. And they're ahead of us in terms of, culling through the data and making changes to the way they treat this group of patients. So kudos to them. It was a great paper. I think one of the things when we look at evidence is sort of looking at, what's a good study, with a good question at the beginning and a good set of data to answer that question. And I think they've done a really good job with that article in assessing things. But you're right, it does affirm, no pun intended, what we're talking about in terms of limiting the surgeries to people under the age of 19.
You note, and maybe we'll get to it later, you have 6 different areas where you just say, we come up with this position paper because of these 6 general areas, but clearly one of those is desistance of the gender dysphoria over time, and it's really difficult to know in whom that's going to happen. But, studies have shown, and it's been since, I don't remember his last name, Paul from Johns Hopkins, but 75 to 95% desistance rate. We've known that for 50 years. And so these irreversible procedures, it seems like it's do we have anything else in all of surgery or medicine in which a problem, a disorder, a psychiatric problem that is going to resolve generally on its own, that we go ahead and intervene anyway? Can you think of another area like this?
Not really. And it's such a great question because some of those who have opposed our statement have sort of tried to turn that question on us and ask the question, why are you holding these surgeries out to such scrutiny? You don't hold any other surgery out to this type of scrutiny. And my response to that is that's just not true. And let me break it down for you. Some of the procedures they use, for example, we do breast reductions in people and women under 18, the age of 16. But there's tons of good evidence and data to support both the physical benefits, leave-ins of back pain and neck pain, and even psychosocial benefits as well. There's tons of data. The other one they refer to often is rhinoplasty. We don't hold rhinoplasty up. But the key there is we don't make the same claims. I never told a rhinoplasty patient that I was going to save their life by doing a rhinoplasty. I never told the patient that your mental health is going to get better by doing a rhinoplasty on you. But unfortunately, those are the claims that are being made with these surgeries. And that's where the evidence is lacking. That's where the data is lacking, is the mental health benefits. You just pointed it out. Not only do patients not just stay the same from a mental health, but they actually deteriorate quite frequently. Yeah. I do want to address the mental health, the psychiatric, psychologist involvement in that multidisciplinary team. Crucial for the point you say, right? We know that there's desistance, and depending on what you read, what number, the vast majority of patients with gender dysphoria, that will generally evolve and go away over time if we leave them. I think what's also important from that psychiatric realm is that psychotherapy is really the core way that these patients should be treated first and foremost before anything else happens. So unfortunately, what we're seeing is, a jump from a very quick psychotherapy session into hormonal therapy and then eventually into surgery. And that's really not doing the patients any justice. So I know that those that oppose what I'm saying will say, well, no, that's conversion therapy. You're taking someone who's truly gender dysphoric and convincing them somehow that that is what they want to be. My father was a psychiatrist, and rest in peace, he was a great psychiatrist. And I used to watch him treat patients, and he will tell you that that's not what's ever done in psychotherapy. Good psychotherapy treats patients for these psychiatric issues that they have. And we know that many of these patients, when they start out, carry DSM-3 criteria, or whatever DSM we're up to, criteria with regards to psychiatric disorders. And so it's important to treat them first from a psychiatric standpoint before we indulge. To your point, there's no other surgery where I rely on the evaluation of a psychiatrist or psychologist before. Do you sometimes get them involved? Sure. There are things like body dysmorphic disorder that I never treat, and I sometimes send a patient for evaluation for that. But never does it guide my care. Usually it stops my care.
Yeah. So Dr. Glasberg, that's going to lead to my next question. I want to take our listeners back in a journey in time, if I can. And you and I have been in practice for many, many decades. And I want to talk about the evolving care here. So in medical practice, in your specialty, my specialty, we talk about the standard of care or community standard of care. And so this has evolved over time. So I want to know your own personal journey as well as your Plastic Surgery Society's journey back when we started doing these procedures and these surgeries. And you hear all kinds of words, gender affirmation care. My state uses gender confirmation care, but then others would say it's gender distortion. Others would say it's sex rejecting procedures. So the language is all over the map. And these procedures were started without any scientific evidence. And let me give my analogy, if you will. Frontal lobotomies were started back in the 40s and 50s based on a Nobel Prize winning scientist who developed this procedure for a real disorder, a real diagnosis, practiced for 3 decades. And you and I were alive back then, and they didn't stop till the 1970s of doing frontal lobotomies. In fact, I was still initial practice, I was taking care of a young person who had one for a seizure disorder. But how did we get started on this path of the procedures we're doing without scientific evidence? I guess that's my question. What was your personal journey and what was your society's journey?
Well, let me give you some personal perspective, and then I could talk about ASPS. I can tell you that what I noted is that in the mid-teens, like the 2016-17 realm, while gender-affirming surgeries have been around for quite a while, the numbers took off exponentially. And one could easily attribute that to the growth of social media and the increased ways that we communicate. And we see that in our field, not just with these surgeries, with many surgeries. Cosmetic surgery took a big turn in the early 2000s because of things like social media, greater acceptance, and things like that. So no one should minimize the power of that voice and that movement to increase. So to your point, though, when it comes to guidelines, when it comes to standard of cares are based on just that, guidelines. And we at ASPS sincerely wanted to come up with guidelines in this area. We knew that our member surgeons were doing these surgeries. It's the basis of what we do all the time. We routinely come up with guidelines documents for a variety of the procedures that we do. But the problem is when we looked into the data, there's just simply not enough data there. And, I don't want to get too much into the weeds, but there are a variety of frameworks that are used to create guidelines documents. And part of that is what's called systematic reviews, where there's usually a question, the question gets answered, and the evidence leads you to that answer. And if it's good, then you can come up with the guidelines. And guidelines consist of a lot of recommendations, and each recommendation is tiered at a certain level. How good is the evidence? Well, if we were to write a guidelines document here, all of them would be of the lowest possible recommendation because the guidance is just not, the evidence is just not there. And where this has played, unfortunately, really in a difficult manner is with WPATH. WPATH is held out there as the quote-unquote standard of care. That's what they call themselves. And they call themselves a guidelines document. And patients and surgeons put their trust in WPATH. And what unfortunately we've come to learn about the process by which these guidelines, these standard of care were brought about, just doesn't, meet the quality that we need in evaluation of data. And, as, a lawsuit in Alabama, Discovery recently showed, there was a lot of influence and pressure politically to put those guidelines forward. And it's unfortunate because, again, patients and surgeons are relying on these things. And so it's a variety of causes as to why these surgeries, why these hormonal therapies started to take effect without, or start to be used without evidence. But it's a whole host of things. It's a litany. It's almost a perfect storm, say, of not following what we, really should be doing, which is following the evidence and following the data. And, I don't want to sound trite, but we say it in our Hippocratic Oath, do no harm. It sounds kind of trite because everybody uses that statement. It probably applies really well here, right? Our primary goal with children and adolescents should be to do no harm. Don't put them at risk. Do what's safest first. And then, if you have the evidence, if you have the data, if you can prove positive outcomes, then you can go on to do surgery.
Okay, so which then leads to my next question, in the future. So we look back, let's look to the future, and I don't mean to make you a prophet or anything, but the consequences that are going to come down the line, particularly for practicing surgeons and physicians in this gender dysphoria for adolescents and children. Now, we had a lawsuit in your state, a couple $1 million for someone, a teenager that had their breasts removed, and I don't know if there's going to be more of this or not. And I do want to pause here and say thank you, and I am speaking on behalf of my boss, our CEO, Mike Chupp. The statement that you now have published this year is profound. And I think
and has a significant ripple effect.
I think it's going to have a significant ripple effect
maybe
to other
on the
societies.
AMA. I don't know if the AMA made their subsequent statement as a result, Scott, of your society's statement or not, but certainly that was about the same time.
Yeah, and I hope other organizations, medical societies follow suit, that you followed the evidence and produced this statement. I will note in your statement, you have a disclaimer on every page. And that's because there is a medical legal consequences to doing procedures. So I don't know what you predict for the consequences. I can just tell you in my state of Oregon, there's zero desire to stop doing these procedures. Absolutely none within both the medical community and the legislative community. And so that also influences public opinion. But what do you foresee in the future? Can you predict?
Sure. Well, let me take it from the standpoint of going back a bit, right? And you're right, Oregon has, there was just a legal decision there that shows exactly what you're saying. There are tons of these lawsuits out there. The one in Westchester was a little bit different. I think the misdiagnosis there was probably, what I know of the case, was probably a patient I mentioned earlier, body dysmorphic disorder. And I had said that that's a red line for ever operating on anyone. So I think that's what got entrenched there. And it was very interesting who the plaintiff expert was in that case. It was actually a gender surgeon. So that case is not a great one, but there are other ones out there. And the future is going to see over the next little bit, a lot of these cases get adjudicated. And I think we're going to be dealing with things of lack of true informed consent and whatnot. But let me make a point that we make in the position statement is this is not a retroactive condemnation of surgeons. I'm going to put on my hat, maybe it's too idealistic, to believe that the surgeons that are doing these procedures are doing them because they truly believe and believed that this was the right thing to do. So in no way should there somehow be retroactive, retribution against those surgeons. But it's a forward-looking statement, to your point. And so, we've now reached the point where we know that the evidence is of low quality and low certainty for children and adolescents. So the hope is that this will stop these surgeries. We're realists. We know that it probably won't stop all of them, but at least we can be on record as a specialty organization, medical organization, of trying to do and recommend what is correct for these patients. If you're asking me what the future holds in terms of data, what I've said is that we will continue to assess the data. And as we've done in other areas, if that data changes, if there's more that's shown, we consider changing our position statement. But right now, there's no indication of that. And part of the problem is that doing studies in this area is just so difficult because of what we talked about earlier. It's very difficult to typically do a study here. So randomized controlled, trials is just not a realistic approach. One thing that I've talked about in many different forums is that if these surgeries are going to be done at all, they should be done in a clinical trial, meaning that if you're going to do the surgery, every bit of evidence that you're able to generate should be part of a trial that then can be reviewed. Unfortunately, right now, given what we know about the data, I don't think these surgeries should be done at all. But if they are for some exceptional reason, then those should be done in a major medical center where there's an IRB and there's an ability to review that data on a constant basis. But there's, I don't see it changing. It's been going on enough. We have enough, evidence or lack of evidence to show that, it doesn't appear that it's going to change moving into the future.
Yeah. Our faith in healthcare listeners are used to hearing me say the following statement: the house of medicine and surgery is broken in this arena. And I say that because of private conversations, Dr. Glasberg, I've had with so many doctors, so many surgeons, psychiatrists, pediatricians in academic settings, where they have to self-censor because they bring it to a department chair and want to have a discussion, and they're shut down. And I just, in my career, I haven't practiced as long as both of you gentlemen have, but I have never, ever heard of anything like this, in which discussions among academicians, people who care deeply about evidence-based, cannot have these discussions. And these are at big places. We're not talking about small institutions, huge places. So my first question is, has there ever been anything in medicine quite like this? And it's, as I shared with you before we got on this program, and I kind of fell into this in 2016, and it was a wake-up call moving from Africa to America, all of this that was going on. So have we ever had this before? And then second, address for us this whole issue, which you have in the position paper, about informed consent in minors, and how in the world you are recommending to your colleagues who want to continue or feel they should continue offering this, maybe in Oregon or elsewhere, how in the world do you get an appropriate informed consent in a 12 or 14-year-old girl or boy?
You guys' questions are loaded. Let's do the first part and say that very unequivocally, there should never be anything in medicine that we're unwilling to speak about. In addition to trying to make myself an expert in evidence, I've also, and this has been my entire 25-year career, is to say that we should always want to get to the table. In another arena, maybe a conversation for another time, I am the co-founder of what's called the breast surgery collaborative community. Breast implants have been a hotly contested area. So what did we do? Me and a colleague from Texas brought together a group of stakeholders, experts, patients, manufacturers, to get in the room and talk about issues where there was controversy so that maybe we can come to consensus. And we have. In terms of ASPS, we may get to this or not. I was pretty instrumental in starting a gender surgery task force at ASPS. It came about because the president's panel that I wanted to run at our annual meeting in October 2024 was forced by petition to be postponed. And out of that, we formed this group to try to build consensus amongst the stakeholders, knowing full well that it might be difficult. And so I'm a believer that we should always be talking, no matter whether we disagree or agree, and trying to build consensus. This is one where it's just very difficult, admittedly, to build consensus. But let me speak to the other organizations. Without revealing names or specific organizations, since I've put myself out there on this topic, I have been reached out to by numerous board members of some of these other organizations, asking me, how did you do it? How did you convince your society to do it? And I've spoken to them at length, and I've tried to, say to them time and time again, as no convincing, follow the evidence. The evidence, will speak to the facts. And if everybody keeps an open mind as to the evidence, then you should land in the same place where we landed without having to convince anyone. I've said this publicly in another interview that I'm calling on every board member or president or vice president of any of these other societies to try to dig deep and take an honest look at the evidence and data that's out there. And hopefully you will come to the same conclusion that we did at ASPS regards to the low quality and low certainty. Unfortunately, as you know, there's other confounding factors that play into this, and that's what's made it a difficulty. So your answer is you're right. In terms of broken, we need to get back to a time in medicine where we're truly doing things based on the evidence, based on the data, and based on what was truly beneficial for patients. And I'll be honest, I forgot your second question.
The second question is informed consent. You said that was another loaded question.
Right. And we'll probably talk about the age of 19 that we included and why, because that's been a hot button topic as well. Sure. One thing that ASPS has done for the last, I believe it's about 15, 20 years, is we offer to our members the ability to use legally, clinically reviewed consent documents. In a time frame where we developed those for gender-affirming surgery in general, not just for minors, we had disclaimers there as well, stating that there's no evidence to show that there's mental health benefits from doing these procedures, and please be careful to tell your patients that. So we're very mindful of the informed consent issues, and now changing back to adolescents and children, we're very mindful of the fact that these patients can consent on their own. I've dealt with a lot of their parents; they're confused. And they are deferring to medical experts to tell them what to do. And it's really one of the most disheartening things that I've heard sort of in this journey of speaking about this. But I've heard it repeatedly, and there's actually some voice recordings of it, is parents being told, would you rather have a live daughter or a dead son?
Yeah.
That is just, that's just heartbreaking, because that tears to the essence of what being a parent is. Of course, we want to do what's best for our children, but we're looking to you to tell us what's evidence-based, not to use some line to convince us, there's that word again, what we should be doing with our children. And, that's come up in a variety of forums, and it's just not where we should be as physicians, as surgeons.
Yeah.
I just want to say one more.
And at some point, you're talking about not looking back, looking forward. At some point in medicine, surgery, something becomes malpractice to do or to say, does it not? At some point in time, we have to say that statement, which we've heard all over the place, it's just not true. It's not true anymore. It's just not accurate.
It's a violation of the standard of care that, transgresses that line that you're putting out there. And that should be a line that we're never willing to cross.
So,
when we talk about risks with patients, and every patient gets risks, alternative, and benefits. One of the alternatives is to do nothing. And that's true of every surgery we do, right? Yeah. Even if you've got a tumor, and this may lead to, I think, a topic I hope we'll talk about, which is this concept of patient autonomy. But yeah, I think it's real important in terms of informed consent to do a true informed consent, to really lay out for my patients all of the alternatives, benefits, and risks, and allow them to make a determination whether or not to go ahead with the procedure.
So, Dr. Glasberg, I want to keep on this idea of informed consent. I want to take our listening audience into your office, into your examining room. And I will tell you, in my examining room, I'll have that 11 and 12 and 13-year-old come in with their parent, one of the parents, and say, hey, this is the next professional athlete in this sport. You must do this, doctor. And so the patient's family puts undue influence on me, the surgeon, and then vice versa. I can put undue influence on the patient and the family, particularly when we're talking about adolescents. And again, I can quote the dead son, live daughter, if I'm in that gender field, which I'm not. But I guess my two questions: one, do we realize the power that we have as healthcare professionals of the influence we have on the patient and the family? And do we realize that they can actually influence our decision by what they demand of us too? This idea of my autonomy, my body, you must do what I want, doctor. How does that look in your office and other plastic surgeons' office when this comes up?
Probably very similar to yours, right? I sit with the patient And depending upon their age, I'm not just speaking to the parent, I'm talking to the patient as well. Because, you know, once you get into that 11, 12, 13-year-old kind, at least you have some understanding. I don't think by any notion you're ready to make this type of life-altering decision, but, you know, enough to, you know, inform them as well. And it's a long conversation sometimes, depending upon anesthesia. You know, these are long conversations, and we do not operate on a patient unless it's an emergency without seeing them twice.
Yeah.
Very often patients, not children, come without anyone with them. And I offer to see them a second time for that informed consent decision so that somebody else can hear, you know, what's being said. And in addition, to your point, anybody who tells you that we don't have the ability to influence is just not being realistic. I don't want to call them liars, but they're just not being truthful. And we know we can as surgeons. I know that I can, you know, convince a patient to, you know, generally do whatever I want. And you know, that's a powerful tool and a powerful responsibility that we accept. And I would just never do that. You know, if a patient, even if they ask me, what do you think I should do? My response is A, B, and C, and these are the risks and benefits of each. Ultimately, though, it's your choice. But let me address another one, because this is a real elephant in the room. This concept of patient autonomy, because people have come at us with this argument that, you know, there's no question that decision-making about a surgical procedure or any treatment should be a shared responsibility, decision-making process between the patient and the physician and the surgeon, right? But the concept of patient autonomy came about to deny care, not to dictate care. And what I mean by that is, you've got a tumor, you've got a disease process, and, you know, you're free to make a decision. It's free will. I just don't want that treatment. It's chemotherapy. It's going to be too painful, and it's going to be, now I'm going to try to convince you that really you may not be making the right choice. Ultimately, that's your decision. But what it's not about, patient autonomy, is dictating care. And why? Because you and I, as physicians and surgeons, have trained to know, you know, the data behind what can and cannot be done and what's medically necessary. I gave an article, an example recently, an article I wrote, that, you know, a patient came to me one time and asked me to shave off their fingerprints. I didn't ask why they wanted it, you know, could I do it? And could I do it safely? Absolutely. Would I do it? I told them absolutely not. Why? Because there's just no medical indication for me to do something like that.
Yeah. That's a good example.
Yeah, and set yourself up as a professional, not a provider. That's one of the things that I'm seeing more and more in the literature. We've been talking about at CMDA for a long time, that we should not settle for being a provider. My next question, Scott, would be in terms of conscience. And Ezekiel Emanuel, during the Obama years, wrote an article for JAMA about that we are not conscripts as doctors. We chose our fields, and therefore conscientious objection, it really doesn't have the same place. And that if our societies, if these guidelines that come from WPATH or wherever say we should be doing A, B, C, D, well, then we just need to get in line, and that there's not a place for conscientious objection, even if we put forward evidence. So I'd be interested in your thoughts, because we talk a lot around CMDA about conscience and what informs our conscience.
Well, this sort of speaks to a little bit of what I was already suggesting is, you know, everybody is entitled to that ability to think for themselves and make a decision for themselves. That can be a patient or it can be a surgeon as well. But for us as medical professionals, as physicians and surgeons, you know, we have to rely upon the evidence and data. So just because somebody comes out with a quote unquote guidelines document, and it may not be in this field, it may be any procedure, the whole point of what we do as physicians, you know, is to move the ball forward and critically evaluate that document. It's the basis of our, you know, medical education process. It's the foundation of my surgical training. I had a great chairman in general surgery. He said two things to me. He said, one is what you don't know fills textbooks. And he also said to me, Scott, the day that you stop learning and critically evaluating, that's the day you retire. And that had lived with me, what was it, 25, 27, 28 years ago. He said that to me, has lived with me, and is an essence of the way I practice. I think we should all be practicing.
So I'm going to ask your advice here. I'm going to ask advice for all our listeners and for myself, where we proceed from here. So you have a very solid statement, just came out in February of this year. The pressures on us practicing medicine, practicing surgery are enormous. We have our medical societies, our community profession, we have public pressure, we have legislative pressure, we have legal pressure, we have the whole culture. So what advice would you give to not only plastic surgeons, but general surgeons, the family practice doctor, anybody that's going to care for a young person with gender dysphoria? Any lasting advice you want to give?
Well, let's start with the empathy part, right? No one is disputing that gender dysphoria exists, and there are patients, young patients, who have this diagnosis. But the key is to putting them on a path to success, putting them on a path to an outcome that is favorable. And, it starts with psychotherapy and things like that, not to cave to political pressures. When we started this conversation, it was very clear, ASPS is in a clinical arena and does not partake in political discourse when it comes to their guidelines or their statements or their policies. Physicians have that same obligation as well, is to stick to what's clinically beneficial for the patient, and it sounds right, do the right thing, based on our training, based on our knowledge, based on our review of literature, based on our review of evidence. I think if we hold to that mantra and core, then whatever we're talking about, conscience, or general feelings or opinions, should follow suit. I mean, that should be the foundational basis of everything that we do and say, and how we treat patients. We need to treat them with empathy, and treat them with respect, and guide them the way that we have learned to guide them.
Yeah, thank you. That's good advice.
Well, I wouldn't consider myself a prophet, but again, when I moved to the U.S., in my mind, Brick, I had a feeling it was going to be plastic surgeons. If anyone was going to turn the tide, it was likely to be plastic, or maybe a gynecologist. I don't know, one of the two, because in contrast to other issues that we engage in quite actively, Brick especially. Brick is medical director of a pregnancy resource center, and we engage heavily on issues of beginning of life. But those the bad outcomes here are alive and able to share their bad outcomes with the world. And it was clear to me that it would be plastic surgeons who would say, we're at the tip of the spear here. If we don't follow best evidence and this doesn't turn out well, we are going to be the most vulnerable. So as we said earlier on, Dr. Glasberg, thank you for the way that you approach this, because it is very winsome and it's very much at the heart, as you've said three times. It's a heart of our profession. Really, we want to see the best outcomes and human flourishing, and we are indebted to you here at CMDA for the position that you have developed. And I hope for, and I'll pray for, a ripple effect to the other societies, especially those like the American Academy of Pediatrics, especially American Psychiatric Association, those that have continued to thumb their noses at Europe and the UK, the Cass report, and say, no, we have our own evidence. We're not paying attention. So any final comments, Brick?
I
wrap up here.
I agree. Again, just express my appreciation to your Plastic Surgeon Society, and I too hope that the other societies will take note. And I will say, unfortunately, for our medical profession, as Mike, you already alluded to, there's a broken house. Yeah. And I hope that they can see not only the brokenness and the harm, but the need to change. And I hope doctors will repent.
Yeah.
I hope doctors
will
repent.
Yeah, we've been talking between us, Scott, about a concept that I don't know that I've heard necessarily in medical history, but an actual reconciliation with the public over how we've not dealt with this very, very well. Yeah. And we should have, not going back to try to throw anybody in jail or put anybody in front of a judge or anything, but just to say, we didn't do this well. And we need to reconcile with our patients and the public. I don't know, your final comments on that before we close?
So I would echo exactly what you both have said. You said it very eloquently. I agree with you. And to my statement earlier, I hope that other societies will look at, this evidence and data and come along in terms of doing a true evaluation and doing what's best in the best interest and well-being of our patients. I'll leave you with one final thought. We didn't have time for it here, but we must not forget those that are detransitioning, those who experience regret and detransition, because they are going through a very difficult time. I can tell you firsthand, before about 2 years ago, I had never treated a detransitioner before. But because I've put myself out there and I actually helped another journalist get care for patients, which she said she was not able to get in other parts of the country, they've now come to my door. And much like we are, say here that multidisciplinary teams are being formed to treat patients with gender dysphoria, I'm now being forced to put together a multidisciplinary team to treat detransitioners. And it's a difficult, painful process for the patient and me as a surgeon as well, because it's just not that much I can offer them because of the irreversibility of these procedures. I do my best to treat them the best I can. I involve my colleagues in other specialties, be it urologist or psychiatrist, endocrinologist or whatnot to help me. But we can't forget about that population as well.
Yeah.
And that goes to the core of what we're talking about here.
Yeah, Dr. Glasberg, I
Yeah.
want to echo that too. So we work closely with an organization called Resilience Health Network, and it's trying to create a network of all specialties. That includes orthopedics. I have patients in my practice that have gone through this care and trying to attempt to change their sex or their gender. So it comes in all specialties. And so we need to create a network of physicians that care, that have the empathy that you so mentioned, to care for these that want to transition back to their biological sex.
Yeah. And in fact, Rick, might as well just say, coming in just 3 weeks, we're going to have a live stream webinar with some detransitioners.
That's correct, yeah.
Yeah. Dr. Scot Glasberg, this has been a delight and accomplished all the things I'd hoped this conversation would accomplish. So receive our best regards, and may many people who hear this rally to this cause of recognizing. I mean, these detransitioners are dealing with regret, and and already have this mental health issue that the Finnish have so carefully documented. So wish you the best. I hope we get to cross paths in the near future.
Absolutely. I hope so as well. And thank you for having me on your show.
Yeah, you're welcome.
Thank you, Dr. Glasberg.
Yeah. Friends, though the house of medicine may be broken, our ultimate hope is never just from medicine alone. It is in our God who calls us to this profession. And conversations like this one are a reminder that He is still at work. He's raising up clinicians from diverse religious and professional backgrounds who are willing to follow the evidence, as well as speak the truth and put patients first. The ASPS position statement is a milestone, but as Dr. Glasberg made clear today, the work, it is far from over. There are surgeons still performing these procedures, detransitioners who need care and compassion, and a healthcare community that we're a part of that must be willing to look honestly at the data. You can find a link to the actual ASPS position statement and additional resources in our show notes today. Friends, if this conversation encouraged you, please share it with a colleague and subscribe so that you don't miss future episodes of Faith in Healthcare. And to connect with a community of believers in healthcare who are living out their faith and calling every day, just visit us at cmda.org. Next week, we're going to be joined by Dr. Bill Clater. He is the recipient of the American Dental Association's Distinguished Service Award. It's going to be a conversation about well-being in healthcare, the role that faith and community play in sustaining it, and what it means to practice with Christ-centered compassion. I want to thank you for listening to Faith in Healthcare. where our promise to you as a listener, or better yet, a subscriber to this podcast, whether you are a healthcare professional or a patient who loves Jesus Christ, is this: we will do everything that we can to keep your faith and healthcare connected. We'll see you next time, Lord willing.